We're streaming live from beautiful Colorado Springs. Thank you to everyone who's attending in person, and thank you to everyone who is online. We're here today to talk about MS with Dr. Robert Gross. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Genentech, Novartis, Sanofi, and Bristol Myers Squibb. This speaker series is just one piece of our education programming. We have a variety of formats available, including in-person and online options, with most of our programs also available on demand through our YouTube channel, which is just YouTube/MS Center. That's where you can find our most recent webinar featuring Dr. John Corboy discussing the DISCO MS extension data and other MS research updates. We also have a fun series called Topics in 10, and that's where we kind of condense very specific topics into short periods of time, not always 10 minutes, but we try. Our latest episodes covered insurance basics with Dr. Kavita Nair and habits for brain health with me. And our next big program is our Fall Education Summit that is happening on November 8th. You can attend in person in Aurora, Colorado, or online. We have great presentations. We have Energy Economics, Managing MS Fatigue with Dr. Maggie Upchurch, AI in the Field of Neurology with Dr. Andrew Wolf, Understanding the Impacts of Comorbidities with Dr. Anna Shaw, and MS Research Updates with Dr. Enrique Alvarez. So be sure to sign up for that if you haven't already. And then again, everyone who signs up is also emailed all of those presentations. We announce all of these opportunities through our mailing list, our Facebook page, and you can also sign up through notifications through Eventbrite. And now I'll introduce you to Dr. Robert Gross. Dr. Gross attended college at Columbia University and medical school at NYU School of Medicine. He completed an internship in internal medicine and residency in adult neurology at Brown University in Providence. He then returned to New York to complete a fellowship in MS neuroimmunology at the CGD Center for MS at Mount Sinai Hospital. He sees patients with MS and related disorders of the central nervous system and divides his time between patient care, teaching, and clinical research. We did have a lot of questions submitted at registration, so thank you for that. We'll get to as many as we can. But today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your own neurologist. And with that, I'll turn it over to you, Dr. Gross.
Okay, well, thank you for that introduction, and thank you to you all for joining us. I think I'll just get started with the questions that were pre-submitted, and then hopefully we'll have time enough for your questions after that, okay? So question 1, is Ocrevus a more effective drug therapy for MS than rituximab? Our 28-year-old daughter's insurance will only cover rituximab. Okay, so Ocrevus or ocrelizumab is an anti-B cell therapy, a highly effective therapy for MS. Rituximab is also an anti-B cell therapy, not technically approved for MS, but we use it for MS off-label all the time. Currently, there are 4 medicines in this category. So there's ocrelizumab, rituximab, ublituximab, and ofatumumab. The first 3 are all IV administered medication, intravenous, and the last one is a subcutaneous. Actually, there are 5. Ocrevus now has a subcutaneous version called Zenovo. I more or less use all of these medicines interchangeably. I think they all have the same mechanism of action, and they're all highly effective at shutting down the inflammation associated with MS. Sometimes it is a question of access or insurance coverage or what have you that kind of, makes you go one way or another, which is not, the way I would like the world to be, but that is the way it is. But in this case, it actually usually doesn't make that big a difference, at least in terms of efficacy. Some people will tolerate one maybe a little bit better than another. You don't necessarily know until you've tried it if you're going to tolerate it or not, but most people do. And so sometimes, depending on the plan, you might be able to get to one if you've shown that you haven't been able to tolerate the other one. So there is that as well. But no, I think in terms of how effective they are, I use them interchangeably. Number 2, are there any new treatments or advances in understanding spasticity in MS? Is a burning/tingling feeling in my left foot and at the base of my skull considered spasticity, or how would you describe it? So spasticity is an interesting area, and it's not just MS, just so you know that people can have spasticity in other conditions. And typically we'll manage spasticity with different approaches, sometimes antispasmodic agents that are pills, so things like baclofen, tizanidine, cyclobenzaprine, et cetera. It can also be managed with, in some cases, implanted pumps that deliver medicine like baclofen directly into the spine. And that can actually be very helpful for some people who have more severe forms of spasticity. And then also there's getting Botox or botulinum toxin injections into the specific area or areas that are most spastic. These all, can be helpful, sometimes more than others, depending on the person and a few other factors. And also things like stretching can be helpful. Certain lifestyle things can be beneficial as well. I'm not sure I would consider a burning, tingling feeling in the left foot or in the base of the skull to be spasticity. Spasticity, I think of as more of like an overactive or a dysfunctional motor system. The same that lets you kind of use the muscles, whereas this is probably something coming from the sensory nerves more than anything else. So I might, if I were evaluating that person, I might try not necessarily an anti-spasticity agent, maybe more like an anti-nerve pain agent like gabapentin or pregabalin or something like that for that kind of burning, tingling, Question 3, is there any progress in remyelination? If so, please describe. Outlook for rebuilding myelin. Good question. So I'd like to say yes. So here, I'm going to use the board. You guys can all still hear me? Good. So if you think about MS treatments, not like the symptomatic treatments like I was just mentioning for spasticity or nerve pain or whatever, but if you think about like things that alter the course of the condition, disease-modifying therapies, in my mind, I split them up into 3 categories. You've got immunotherapies, you've got non-immune neuroprotective therapies. I got to come up with a briefer description of that. And then you've got remyelination or other repair type drugs. Okay. At this moment, we have probably more of this type of drug. And we have nothing of those types of drugs, right? Which is sad and unfortunate, and obviously not the situation that I would like to have. So neuroprotective therapy. So this would be like, we know that some people with MS, even despite going on what I would refer to as a high efficacy therapy, will still continue to progress. So despite our best efforts, some people will continue to get worse. So can we find something that can slow or halt that progression? I say non-immune because we've tried immune stuff for those people, and some people will still progress. So maybe we just haven't hit the right target yet. Yeah, I guess it's possible, but I think it's more likely that there are other factors at play, something that we don't fully understand yet, and that we would like to understand. And so we've tried, there have been a few different studies in recent years trying to find something that would be in this category. And so things like high dose of biotin, which is a B vitamin, lipoic acid, which is another kind of supplement, high dose of simvastatin, which is a cholesterol lowering medication. What am I forgetting? There's been a couple others. So in each one of these studies, we had kind of small data from some people with MS who are progressing that suggested that taking one of these things, and it could be, depending on the study, I mean, they could have allowed, on top of existing immunotherapies or whatever, but we understood it to be like, this wasn't, whatever they were on wasn't really working. So let's try something in addition versus placebo. So in each one of these instances, there were smaller studies that suggested maybe they had some promise. And then when they tried to replicate it on a larger scale, just didn't work, So I think we'll get there. Hopefully we will get there. But so far, we haven't really seen a whole lot of success with these or other kind of supplementy kind of things. Is that hand raised? Yeah. Lipoic acid or alpha lipoic acid. It's a study that was fairly recently completed on that in progressive MS. Yeah. And then remyelination or repair agents, there's some questions, I think, also lower down about specific things, if I'm not mistaken, or maybe that was the other one. Well, in any case, we haven't found one that reliably works. And again, in recent years, there have been a few, interesting ideas that have come up. This drug called ocrevus, for instance, comes to mind, where they had some early studies that suggested, oh, this could be interesting. The way it works in the test tube, for instance, or in mice models, kind of thing. But it's always the rub, when you actually try to translate these things to human beings living with MS and seeing, does it actually work? And sometimes, and all the time so far, it just doesn't. Or there's like a hint of a signal, but it's like, it's essentially nothing, There are still some drugs that are in trials now. One that I get asked about a lot is pipe. Sorry, 307. This is a bad handwriting. That's a drug in phase 2 studies now that is looking at whether it can promote remyelination. And I always tell people, look, I can't see the future. I don't know what these studies are going to show, but it's hard for me to get super excited about something until I actually see, data in front of me that says that this is working or it's not working, So I'll keep my fingers crossed, and we'll see, but I can't speak specifically to whether that's going to work or it's not, Maybe I'll just move on from there because I think that we're going to come back to something on that graph soon. Okay. Okay, yes, next question. How effective do you think is the new BTK inhibitor tolebrutinib? How effective will it be at slowing progression? And do I feel it can interfere with type 1 diabetes? Very interested in BTK for secondary progressive. And then asks about like when it becomes available, costs, coverage, and side effects, etc. So tolebrutinib is from a new class of well, it's not new, but it's new to MS class of medications called BTK inhibitors, or Bruton tyrosine kinase inhibitors. These are proteins, enzymes that exist in different cells, and they're interesting here in MS because they work both within your B cells, so your immune system, and then also they work on in other innate cells of your central nervous system, like your mitochondria, which we think might have an important role in MS. So this drug, tolebrutinib, several drug companies have decided to try to come out with their own version and test it in different types of MS. And initially there was kind of a lot of hype, and then the first studies started coming out in relapsing remitting MS, and it was like, well, it's not really that effective. Like, for instance, another one, evobrutinib, was found to be no more effective than Aubagio or teriflunomide, which was, it's not one of our more effective medications for MS. And so then it was kind of like, oh, this medicine, tolebrutinib, had a trial in secondary progressive MS that met its endpoint, meaning it slowed the rate of progression in people with progressive MS compared to placebo. And so it joins the ranks of, relatively few medications, I think really only 3 that I can think of, that have had positive studies in progressive MS. And interestingly, I think we have some saved videos, maybe from Dr. Alvarez, talking about this in more detail. But interestingly, again, with this medicine, like its other one in the same class, it doesn't really seem to have a strong anti-inflammatory effect. Like maybe it acts, it like reduces the amount of new lesions like a little bit, but not like all that much. So it does seem to be maybe acting more by a non-immune based mechanism. And so it's currently being reviewed by the FDA. Initially, we thought we were going to get approval like a few weeks ago, and now it's got pushed back to December. So we'll see if and when it gets approved. I assume it will. There will likely be a REMS program, meaning we're going to have to do some kind of more intense monitoring. There have been cases of serious liver injury associated with this drug and with this class, including deaths. And so likely it will include a lot of close monitoring for liver dysfunction. And yeah, I mean, if it does get approved, I'm sure there will be some, it'll take a little while for insurance companies to figure out, their coverage policies and so forth. But well, yeah, I mean, it will probably get covered. But I mean, how much that will end up costing you, I mean, I would just have to speculate at this point, right? Next question, is fasting, so maybe I'll put that up here too. All right, next question. Is fasting good for multiple sclerosis body? Well, I can't say really yes or no. I mean, fasting as a rule, like your body needs some sustenance to survive. So without knowing more about the kind of, what type of fasting this person would be doing, I have talked to people who really, in my view, kind of take it to the extreme. And I'm like, I think that's gonna like start shutting down vital processes. There have been, I think, some small studies looking at the benefits of intermittent fasting in MS. And to my mind, I think that it's not necessarily a proven therapy for, just people at large. And, as with other kinds of diet changes, especially kind of the more restrictive ones, it can be tough to sustain. I mean, that's why people will diet for like a few weeks and then they'll kind of revert back to their old eating habits, because it's hard to change your diet, especially something like intermittent fasting, which we're so used to kind of eating on a regular basis. But for those who are motivated and who choose to do it, I've had people come back and say, "Oh, yeah, look, I've lost weight. I feel more energetic," and things like that. So there may be some kind of overall health benefits, maybe depending on your situation. But I would certainly do it with with consulting a physician, maybe your primary physician, making sure you're not having excessive weight loss or missing out on essential nutrients, kind of thing. How do you keep your brain healthy? How do I, or just in general? Well, you keep the brain healthy in a lot of the same ways we keep our overall body healthy. So a balanced diet, avoiding excess, sugars and excess, bad stuff, processed foods, kind of thing, plenty of fruits and vegetables. an active lifestyle. So it doesn't have to mean going to the gym all the time, but doing something to get your body moving a few times a week, kind of thing. Good sleep. I think sleep is very important, and it's often neglected by a lot of people, doctors included. Paying attention to your kind of physical health as well as your mental health, because I think, again, mental health, like sleep, tends to be neglected. And then avoiding like the bad stuff. So like cigarettes are really bad for you, guys. Really, just stop smoking, please. Cocaine, also very bad for you. Don't do that. It probably, we don't know about MS specifically, but just for brains in general. So yeah, I mean, I think if you can do all those things, you'd probably be in pretty good shape, So those are the kind of basic health promoting, advice for everybody, really. Okay, tips for managing bladder issues, chronic strep B UTIs. So yeah, bladder issues can be a source of struggle in folks with MS, because in some people the bladder doesn't empty properly the way it should, and that can become like a source for bacteria to kind of grow. Frequently, we treat MS with immunotherapies. Immunotherapies can lower our ability to fight off certain infections, and so that can also kind of exacerbate this tendency. And so urinary tract infections are something that unfortunately our patients may experience recurrently. And if that happens, there's a few different kind of pathways to go on. First, hopefully you'll be seeing another, you'll see your neurologist. Hopefully you'll also have a urologist, a bladder specialist that you can work with. If it's because your bladder is not emptying, as it should, we can try medication sometimes, and also the urologist might recommend intermittent catheterization to get the kind of old urine out of the body. Antibiotics, when you have an infection, that can be important, but then also sometimes people will need daily preventative antibiotics, even when they're not sick, to prevent them from getting infections like urinary tract infections if they are especially prone to them. So it's kind of a combined approach that can sometimes have to happen in folks with those issues, but they can be thorny. Okay, how important is neurotesting for cognition? So cognition, the way we think, how efficiently we do so, is also an area like your bladder that can become affected in MS, and commonly is. Neurotesting, by which I assume the person who's asking about like neuropsychological evaluations, it's like a several-hour process by which a trained professional neuropsychologist, they'll ask you, basically questions on testing every domain of your thinking, your ability to form new memories, your language function, executive function, all of these things, and then they're able to spit out a report that says like, okay, this is where you seem to struggle, this is where you do okay, relative to your peers, and sometimes they can give us tips as far as like, okay, this is a pattern that you commonly see with MS, or this pattern is really consistent with Alzheimer's disease or some other kind of neurological condition, or there's a combination of things that could be contributing: the poor sleep, the depression, the multiple medications that are centrally acting, et cetera, et cetera. And then finally, sometimes they'll give, or actually I think always they give kind of tips for how to deal with the symptoms that you have. And so kind of workarounds if need be, and then healthy mind promoting activities that you can do, which usually involve some kind of reading, keeping the mind active, puzzles, games, whatever, that kind of thing. And so is it important? I mean, yeah, I mean, it can kind of tell you where you're at right at that moment, and so then if a few years later we're hearing again that thinking is a struggle, maybe we repeat it and we see, actually no, you're pretty much exactly where you were 3 years ago. So that means you're not really declining. It's just you're continuing to experience the same things, which can of course be bothersome, but it doesn't mean that that represents a decline. I don't need to worry about, oh, maybe there's some additional thing happening to you or whatever. And so it gives us kind of an objective marker. Okay, this is where you're at this moment. And so, yeah, I think it's pretty important. At least at the university, I've been referring a lot of people to them, so I think there's a pretty significant backlog. Okay, so if you get a referral and you have to wait a few months, sorry about that. Okay, I'm interested in hearing about vision issues associated with MS and suggested treatments to improve them. Vision, another commonly affected area by MS, and this can kind of come in two flavors. One, what we call afferent, or coming towards you, or efferent, kind of going out. So afferent would be like how you perceive the world. Your eyes are used to kind of take in all the visual information around you and then send it to your brain for processing, right? And then efferent in this case would mean like the muscles that your eyeballs use to move around. Okay, and so an afferent problem that happens in MS might be optic neuritis, or inflammation of the optic nerve, which is kind of that first path of getting that visual information from outside to the back of your brain. So optic neuritis is a common kind of presenting feature in MS, and it can happen as a relapse in people. And it involves decrease in vision. So your vision can get a little blurry. It's rare to see in an MS attack of optic neuritis the vision go kind of completely dark. It's usually more of like a blurriness kind of thing. And then for efferent, or kind of the control of the eyeballs, a common thing that folks with MS will get is called an INO. It basically means the eyeballs are not completely aligning. So like if I try to move my eyes to one side, this eye will move to that side, but this eye will kind of stay looking straight. And when that happens, when the eyes see two different things, it produces a double image, okay, which can be uncomfortable, and so people prefer not to do that. But in both instances, I mean, you're kind of compromising the vision. So if one of those things comes in the form of an attack, then as with MS attacks, we would treat it with steroids usually, and we would hope for full recovery. Sometimes that happens, sometimes it's a partial recovery kind of thing. And sometimes people, if they did not recover from an initial attack and they just have this persistent kind of visual disturbance, then yeah, I mean, there was no other part of that sentence. It's really just that can happen, and yeah. And so how can you improve them? Well, I mean, I think having close contact with your neurologist, having a relationship with an eye doctor like an ophthalmologist can be helpful too. Sometimes in certain situations, we might refer to a special neuro-ophthalmologist who is a neurologist trained in the ophthalmological arts. Treatments to improve them. Well, again, if it's an acute attack, we might give steroids. If it's something else, and I do, that's part of the reason why I strongly believe that folks with eye issues should also see an eye doctor in addition to a neurologist, is that it can often be something that's not MS related, that lots of other stuff happens to the eyeballs, especially as we get older. There's macular degeneration, there's floaters, there's a million other things. And so a lot of times people will assume that it's their MS, but then it turns out not to be. And so yeah, so if it's something else, obviously treating that condition. And then, if it is the MS and, it's been around for 5, 10 years, 30 years, whatever, then, again, I would love for there to be a remyelination or repair trial that can bring back that function. But at this moment, we don't have it. So I wonder whether there are exercises you can do. I mean, there's nothing that I can really think of that would, help. If the muscle is weak, we would recommend physical therapy to try to get it back up. With the eyes, I'm not sure what kind of peering into the distance you can do to make it any better. All right, moving on. Okay, can you please explain transverse myelitis relative to MS? When and why might it occur? What kind of symptoms and what percentage of people with MS experience transverse myelitis? So, okay, good question. So like optic neuritis, transverse myelitis really is just describing an episode, a type of attack that can occur. It doesn't tell you what is causing it. So people who don't have MS can get transverse myelitis just like they can get optic neuritis. It doesn't happen commonly, and often it can be like after some kind of a significant illness or something like that. But in the context of MS, people can experience it over and over again. So the relapsing type, part of relapsing remitting MS is you having relapses, and often that can be in the form of a transverse myelitis and then another transverse myelitis or something like that. I say often, hopefully not often, because hopefully people are being treated and that's not happening. So it's a clinical syndrome more than it's telling you, what's causing it. But we assume, in everybody, not just in people with MS, that it's got some inflammatory kind of, it's being caused by, I shouldn't even say this. It can be caused by autoimmune inflammation. You can also get transverse myelitis because you have a spinal cord infection. Sorry, I should have started with this. So transverse myelitis refers to inflammation of the spinal cord. I assumed that was common knowledge, but I shouldn't have assumed that. And so, like other, MS attacks, it can happen just kind of randomly. You randomly got an optic neuritis, or you randomly got a transverse myelitis. And so it's very common. I don't know exactly what percentage of people with MS get transverse myelitis, but if you look at the spinal cords of people with MS, a good half of them will have lesions in their spinal cord, if not more. And so I imagine symptoms related to damage to the spinal cord, whether they came in the form of an observable attack or not, they're very common in MS. And the kinds of symptoms they produce include things like numbness, tingling, especially involving the leg, but can also be in the arms, weakness, heaviness, clumsiness, difficulty walking, difficulty controlling your bowel or bladder. So those are, actually often the symptoms people associate with MS are the symptoms of damage to the spinal cord, such as what can happen in an attack of transverse myelitis. And as in other attacks, we can treat it, we hope it gets better, kind of thing. And then if a person has MS, obviously we're going to talk about putting them on an immunotherapy. What are the latest thoughts about high oligoclonal band counts and high CSF kappa free light chain findings? Okay, so oligoclonal bands are one of the main tests we use in diagnosing MS. It refers to the production of antibodies in your spinal fluid compartment, which not supposed to happen. We all produce antibodies in our blood. That's kind of what makes us immune to lots of different things. But the spinal fluid space is supposed to be protected, and so you're really not supposed to be producing antibodies there. And if you are, that means there's something going on there with your immune system that's not right. And so, it's not specific to MS, but we use it in the right clinical context as indicative of MS. And then this free kappa light chain thing is actually very similar to oligoclonal bands. It's might be a little bit easier. Still requires a spinal tap, so it's not actually saving you from that. But it might be easier for some labs and some institutions to perform that. So in the latest hot off the presses version of our diagnostic criteria, we are now allowed to use either of these, test results towards the diagnosis of MS. I'm just very much used to ordering oligoclonal bands, and I'll probably continue to order that when I'm looking at MS diagnoses. But but this other test is also now available. How much does perimenopause or menopause play into diagnosis? There's been studies that have shown that people who are undergoing perimenopause or menopause can, with MS, can have kind of an increase in some of their symptoms. Sometimes it can be a little hard to tease out whether that's the MS that's kind of becoming more noticeable, or if it's like it's really because things like fatigue, or if it's more like, I need to like stick my face in the fridge every 5 seconds, you're like, okay, well, that's like a vasomotor symptom. That's probably the menopause, not necessarily the MS. But it's tricky too, because if you look in like population studies or whatever, when women go through menopause is also the time, traditionally when people with MS will start to enter into the secondary progressive phase of the disease. And so there's questions, and because, frankly, we just don't understand enough about progression. We don't know what causes it. That said, we haven't really ever proven that doing hormone supplementation, for instance, is a useful therapy for preventing MS. So I wouldn't put it in there, for instance, or in preventing the progression of MS, I should say. Or in preventing, the inflammation associated with MS. So it's not an immunotherapy either. It's not a remyelinating therapy. It's nothing. But if you are experiencing, for instance, hot flashes, it might make sense for you to go on something like an estrogen replacement. But usually it's not going to be us, the neurologists, who are going to prescribe it. It'll be like your primary doc or your GYN or something like that. And in that instance, I'm fine with that. That's, if it's needed, yeah, for sure. And it probably has not much or any impact on the MS itself. Okay, next. Is there any information on the long-term negative effects of B-cell depletion therapy, such as greater incidence of cancer? Yeah, there's some. B-cell depleting, well, really all of our immunotherapies, but we'll take B-cells because that's what they're describing here. And again, those are the currently available ones that I mentioned, ocrelizumab, ublituximab, rituximab, and ofatumumab. The long-term effects of depleting some of these B cells include greater incidence of infection. You're at higher likelihood for getting sick. Not like 100% more likely, but there, on average, on a population level, there's a slightly higher incidence of people getting sick on those medications compared to, say, on nothing or on something like your earliest generation injectable agents. And of course, a lot of things go into whether a person gets sick, including who they're around. If they're a school teacher or a parent with young kids and they're constantly, are in a germ factory, then they're probably going to get sick more, right? Versus if you live on your own, you're in the mountains, you don't communicate with anybody else ever, then you're probably not going to get sick a whole lot, right? So it's not just about, what we're doing to your immune system. In fact, B-cell depletion only depletes a very small proportion of your circulating immune cells. You still have all of these other immune cells out there that should be, fighting and doing the things that immune cells do, which is protecting against infection, also probably preventing you from getting cancer. So in the ocrelizumab original studies that led to its approval, there were a handful of cases of cancer that occurred. In particular, I think breast cancer was like, there were like half a dozen or something like that out of a few hundred people. And so initially when it first came out, there was this whole hubbub about that, and it was like, well, is it increasing person's risk for breast cancer, which is potentially very serious. The company has been doing kind of regular surveillance on this topic, and they have not found a higher incidence of cancer of the breast or of any other type, last I checked, compared to other MS populations who are not on this medication. And so, yeah, I think it is Probably not a huge issue with cancer. There was one study in particular that I'm thinking of that looked at kind of lots of different treatment types and found, I think, an increase on a population level of B-cell depleting therapies and alemtuzumab, which is another high efficacy medication, towards increasing cancer risk. But that was the only study that I can think of that has this. So if it is, it's a small one. We're certainly, I mean, we've been using these drugs now for 10, 15 years, and it hasn't like, and many of our patients are on this form of medication. And we're not hearing like everybody come back in like, yeah, I got this weird, whatever cancer that, nobody else in the world ever gets, but I got it. And then the next person, that has not materialized. Yeah, so. But you are right to ask about long-term issues. You should ask anytime you see a doctor, if somebody wants to put you on medication, how long should I be on this medication? What are the potential long-term ramifications of being on this medication? In general, though, I mean, we use them because we think the benefits are usually up here and the risks are usually down here. Now, if that's not the case, for instance, we have some later questions about what happens when as you're aging on these MS disease-modifying therapies. Then, maybe the curves are a little bit closer, or maybe risks are higher than benefits, in which case, maybe you want to take a step back. Okay, next. Oh, yeah. So if you're diagnosed later in life, 57, is it still recommended to stop DMTs after age 60? And I think we have, the next three questions are all about age and disease-modifying therapies. So first, I'll refer you to Dr. Corbo's recent talk, right, on the results of the DISCO MS trial and the extension. So big picture, we don't really know how long a person needs to be on these medications for. In the vast majority of instances, we don't think it should be like a year or two. We think it should be many years, right? But probably not your whole life. Right? Probably not your whole life. And why is that? Because the part of the MS that these immunotherapies can control, the part that's is most active in the first few years of the condition. Okay, so in almost pretty much every study that I'm aware of, if they've done subgroup analyses, if they've looked at the benefits of these drugs by the age categories, inevitably it's the youngest people, it's the people who were most recently diagnosed with MS who seem to benefit the most. And if they have signs of recent or ongoing inflammation in their brains, which in natural studies of MS, that is mostly in the people who are the youngest and the most recently diagnosed. If they have those things, then yeah, they're going to probably benefit from these disease-modifying therapies. If they're older, if it's been many years with the MS, if there hasn't been any recent sign of inflammation, for instance, on their MRIs, then people are really unlikely to benefit from our currently available disease-modifying therapies. Which is not to say, though, that if we ever get any of these, that they wouldn't be helpful later on. So if you can imagine, like, you get diagnosed with MS. We have all of these now available, okay? Like that, okay. You get diagnosed with MS, we're gonna wanna put you on an immunotherapy, calm down that acute inflammation, okay? And we're gonna wanna do it as soon as possible, and we're gonna probably wanna keep you on it for the first several years. Neuroprotective therapy, so say we find something that can reliably provide protection in all cases, we'll probably wanna start it right off the bat as well, right? If it's safe, if it doesn't cause decrease in immune or other bodily functions, then maybe you stay on it forever. Maybe we put it in the water, A remyelination therapy, maybe you would use right off the bat after you've had an acute attack and you want to rebuild or remyelinate those neurons. And then, it's done when it's going to do, in a few weeks or months or whatever. you stop it, and then you just continue on those other treatments. So, I can imagine this kind of layering on of things that would happen. And then, after a certain point, let's say we can tell you don't really need the immunotherapies anymore. So then we peel that away. But you might stay on a neuroprotective therapy, for instance. This is all now, you can tell, it's like theoretical. I hope we get some of these other things. We just don't have them right now. But that wouldn't necessarily depend on age. So what depends on age now, and what we can tell now, is that the benefits seem to go down over time. Not because the drug itself wears off it's not because of the drug, it's because of the person. The inflammatory part that was more predominant early on doesn't seem to really be at play as much. And then as I was saying, you got the benefits and you got the risks. As we get older and our immune system's kind of naturally weaken anyway, and then especially if you're on a medication continuously, over many years, that depletes your immune cells, there can be a kind of a cumulative, risk associated with that, especially as regards kind of, infections, getting sick, that kind of thing. And so if we judge, we talk to you and we all kind of agree that it seems like what we're doing now is not helping, maybe hurting you, versus it doesn't really seem like we're doing, the benefit is there at all, from what we can gauge, then that doesn't make sense that we should keep treating, right? Like, you don't want to be on something that's causing you harm, and that's the first thing that we are taught in medical schools: first, do no harm, right? And so if something is harming you and not helping you, then it's not worth it. Trouble is, you can't always tell when that point is. And so it's always this kind of dialogue that we have, and this kind of calculation that we have to do is, what exactly do we think the benefit is, and what exactly do we think the risk is here? And it can be tricky to judge, in part because, we need better tests for monitoring MS. We have what you tell us, we have the examinations, and we have the MRIs. And so those can give us something of a picture, but I'd say it's still kind of crude. And so if we could get more kind of granular into what's happening in your nervous system at any given point, that would be interesting. And then we could really tell more about, well, how are you actually declining? And so how quickly, and can we change that slope at all, with this thing or that thing? This could be useful for like trials of new, protective agents. Where did I start with that one? B-cell therapies, right? Yeah, no, older age, yes. Okay, thank you. Yes, I was having a senior moment there, yeah. Question from the audience.
When you're getting a drug therapy, and like my doctor asked for blood work and talk about counting those B cells. So what do you gain from that? And if it's low, do I continue to go get that drug therapy?
Honestly, I don't gain very much from that. Good question. She's okay. So the question is about, I don't know if I get picked up. No. Okay. So the question from the audience was, what is the benefit of monitoring blood for the presence of B cells if you're on a B cell depleting therapy? So, so there are certain, kinetics and dynamics associated with these drugs, and then with the IV ones that are the most common, so ocrelizumab, rituximab, if somebody gets one of those, even like at a single dose, their B cells are going to remain gone. They're going to be eliminated real fast, and then they're going to stay gone for a period of months, typically. 6 months is around the time that a lot of people will start to repopulate those B cells. And so it is the time that we often redose these IV forms of B cell depleting therapies, because we want those cells to stay gone. They're not all bad, they're not, but we can't really readily tell with the good ones from the bad ones. We just get rid of them all. When they start to grow back, which they inevitably will if you given enough time, and if we don't hit you again with more of the drug, it doesn't necessarily mean that a person is at an increased risk for an MS flare. And so it's kind of one of these tests that, we order because we can, and we know that that's how the drug works. So it feels like it's measuring the working of the drug. But, if I tested somebody at 3 months, everybody's going to be gone. All the B cells are going to be gone on everybody. So, and what does that tell me? Versus if I test somebody at 9 months, a lot of those B cells are going to have recovered, but most of those people are going to be fine. They're not going to be having MS flares. And so this actually comes up because one of the topics that's near and dear to my heart is this idea of, how much of these drugs do we really need to give, and could we get away with giving it less often? And I think for most people, the answer is yes, that giving it once every 9 months or giving it once a year is probably the same in terms of efficacy, but it probably reduces your risk for some of these long-term issues. And so, yeah, I don't really bother too much with that particular number, the presence of B cells. And I'm sorry, I think your question was, if they're gone, is that a bad thing?
So I'm about to go to infusion again.
Yeah.
And my B cells are like, nothing.
They're still gone.
They're still gone.
Yeah, yeah.
Would I still go for the drug therapy, even though there are no B cells showing up?
Yeah, I mean, a lot of people will still have no B cells at the time of their infusion. That's just, we're like, yeah, because we gave you something that knocked out your B cells. But I mean, in the larger sense, like, depending on what your particular, situation is, you may want to ask your doctor, hey, I've been doing this every 6 months for X period of time, and I've seemed like I'm stable. What do you think if we were to do it every 9 months or every year? Cool. And where was I? Older people discontinuing drug. So we don't have a magic number. I don't have a magic number. I don't say like, okay, you hit 55, or okay, you hit 60, we're done, cutting you off. No, I don't do that. And I don't think there's any insurance, any payers that are doing that at this point either. You got to look at it on an individual basis and say like, do we think this is working? Like, what are the risks, things that I was talking about just a moment ago. And so, it is useful as a guide. So what are the data? So, so there were a number of observational studies that looked at kind of what happens to people after they go off their immunotherapies. And one of the things a lot of people are interested in is just age. Like, what if you do it by age? Like, so if you stop your disease-modifying therapy when you're 35 or 40 or 45 or 50, 55. So it turns out after age 55, but certainly after age 60, the vast majority of times when you stop your disease-modifying therapy, nothing happens. Nothing observable happens. There's not a big new attack kind of thing. On average, in large kind of populations of people with MS. And so on the basis of this, we participated in this trial, the DISCO MS study, which you can hear about more from Dr. Corboy's talk. Essentially, people who are 55 or older, stable on their respective drugs for the past 5 years, were randomly assigned to either continue those drugs or stop. Okay. And you knew which, when you were told, you knew which one you were. And then the two groups were compared at the end of the study. And what they found was essentially very few people, whether they were on drug or not on drug, had an actual relapse. It wasn't statistically significant between the two sides. Very few people had there was no significant difference in level of function from one side to the other side. Where there was a slight difference was that a few more people who stopped drug ended up having something change on their next MRI compared to people who continued on drug. So when and usually it was just like a small little dot here, 1 or 2 dots. They're not of clinical significance. But when they crunched numbers, they couldn't definitively say that the study showed equivalence or what they call non-inferiority of stopping to continuing. And so, though in most people who stopped, nothing happened. Right? And so is adding to the kind of body of evidence that we have about this part of MS and what can we do? What should we do? And I think, there's probably a number of people, who are on drug, or are older, who've had MS for a long time, who may not really be getting any benefits from that drug. And it may be just costly and exposing them to potential side effects. So something to discuss with your doctor. Okay. I was diagnosed with MS, presumably, May this year, 2025. Oh, so recent. And concerned about med side effects. I don't want anything that has shingles as a side effect. Have had the gallbladder out, so nothing to filter to protect the liver. Okay. So I got to be cautious about the liver and want to avoid liver damage and shingles. Well, we want to avoid those things too. No medication is without the possibility of risk. People talk about side effects from medications just in general, like, well, I don't want that medication. It has it's as a side effect this, when really no, it has as a possible side effect that. But most people who go on that medication probably will not have that side effect. But it's hard to kind of communicate that, like, especially, you see them on the commercials and they have this long list of, possible, including the, you could grow a second head and, whatever. And you're like, oh, I don't want that. So yes, any medication has the possibility of side effect. Otherwise, it wouldn't work. If there were absolutely no possible side effects, it'd be like water. It'd be like inert, not no benefits at all. But we obviously we try to monitor. We try to choose a medication if we can that we think is got the right kind of risk benefit profile for folks. And so somebody who was recently diagnosed, since I don't know the more of the details here, somebody who's recently diagnosed, presumably they had recent disease activity, they should certainly go on a medication. At our center, we tend to try to get people treated with more high efficacy therapies. So a lot of these are your IV therapies, your B-cell therapies, and then some subcutaneous and oral treatments as well. But we try to get kind of, people off the bat started on what we think are going to be more effective treatments rather than waiting on, treating with less effective treatments and then only escalating when we think things are bad. So it's a kind of about trying to figure out, in consultation with your doctor, kind of what medication seems like the right one for you based on what the risk profile is and, what you hope to achieve by controlling the MS, right? Because that's an important consideration, right? And so, yeah, you don't necessarily want to focus too much on the possible side effects because a lot of the times those are not going to happen. With liver damage and shingles specifically, I mean, yeah, a couple of our drugs can have the possibility of liver damage, and it's something we would monitor for. And if you started to see some elevation in liver enzymes, you would take them off, and hopefully they would just go back down to the normal range. I can't count a couple times that that's happened. My few years of practice. But depending on the drug, depending on the whatever the person's maybe innate liver function might be. And then shingles is reactivation of the zoster virus, the one that causes chickenpox as well. So it lays dormant in your nerves, and then it can pop out when you least expect it, and it can be very painful. It has this kind of characteristic rash. It's apparently really uncomfortable, and we don't want people to get it. People can get it who are not on immunotherapy. Some of our immunotherapies increase the possibility that you would get it. So again, kind of trying to balance out that, what is the likelihood that I would get it versus like, how much benefit is this thing going to give me? And, you work it out. How are we doing on time? Oh, time flies. All right. Okay, so recently published information or publicized information about the potential brain health and neurologic benefits of creatine supplementation. Okay, yeah. So I think I have a creatine, and then lower down I have a creatine or carnitine question. So I haven't, I hadn't seen that specifically recently, but I was just reading the questions and I was like, oh, well, let me like, there was a review article on the possibility of, or the potential benefits, I guess, of creatine in MS, as there is if you Google like X plus MS, you will get a review article that talks about the potential benefits of that thing. But usually that's as far as it gets, potential, because we have this idea, or maybe it's motivated reasoning or whatever, that this thing can potentially help. But then, for me, it needs to be proven. And for that, you have to have a clinical trial involving people, real people with MS, and seeing, does the drug work compared to something else, like a placebo or a control. And before that happens, it's all speculative, And so I would say a lot of the supplements and vitamins and things like that, we don't have solid evidence of the ones that we have studied, they usually don't work. With the possible exception of vitamin D. Vitamin D is the one that is, for long has been associated with having low levels of vitamin D increases a person's susceptibility to getting MS. Low levels of vitamin D are associated with kind of greater amounts of inflammation in MS onset. We never really had convincing evidence that taking vitamin D or giving it to somebody who has MS actually does a whole lot. But then there was a recent study out of France that was actually pretty well done and looked at higher doses of vitamin D compared to placebo in people who had an initial clinical attack like MS, and really most of them had MS. And they looked at the time to subsequent attack. And they found that taking a high dose vitamin D protected them from having a subsequent attack. This was before they were treated with immunotherapies, and we would have just been like, okay, let's give you an immunotherapy and then let's prevent that second attack. But that is not how that study went. So it did provide, I think, pretty definitive evidence that it is doing something. That we know vitamin D has immunological properties, and so it makes sense that it does something. I just think that, at least in terms of the kind of metrics we will often look at in MS, relapses, MRI changes, things that are kind of inflammatory stuff. You go on an immunotherapy, vitamin D is probably a wash. You're probably not getting much additional benefit in terms of that, but maybe it has other benefits. Maybe it's neuroprotective. Maybe it's anti-cancer. It's good, certainly good for bones. And so we're usually recommending folks take vitamin D because, as a thing that's most proven, But still, very much wanting to find that supplement or whatever that's going to provide like definitive evidence of benefit in MS. Yes.
What is considered a high dose of vitamin D?
I was hoping somebody didn't ask me. I don't actually remember. I think it was around, I think it was 20,000 units every other week, which is the same as like 10,000 units a week, which is what we will often use to treat. Somebody can double check me on that, what dose they used in that study. But it wasn't like crazy. It was like a normal dose, just higher than you might be able to get with, no, not even necessarily, but like, you could probably achieve that amount through kind of over-the-counter supplementation stuff. But if we see somebody's level is really low and we want to get them up quicker, we'll just prescribe them. Sorry, did I say 10,000? I meant, sorry, scratch that from the record. Typical dose that we would give is 50,000 a week, but I think they use 100,000 every other week. Yeah, so forget my initial numbers, 100,000 every other week. Yeah, exactly. Okay, so you could get to that amount if you were taking like 5,000s and 10,000s and stuff like that. You just have to take a bunch. Yeah, exactly. Yeah. So the 50,000 comes as a prescription usually. Yeah. So yeah, good. All right, so we're going to continue. Are spine MRIs unreliable for detecting new lesions because of the tininess of the cord, floating in fluid, and movement during scan? Yes. I don't know if that was meant to be an or, but yeah, it's probably all of those things. MRIs have certainly come a long way. We can see a lot now that we couldn't see even just a few years ago. Brains especially are looking very like, you can see things that you're like, oh. And in fact, that causes us some trouble because sometimes we'll have like a newer, really kind of, LED screen kind of image, and then we'll compare it to an older one from like 20 years before, and you're like, there's only 2 slices here, and they're saying there's a new lesion. Well, yeah, but I don't know, was that lesion there before? Right, so that can be a little source of trying. So MRIs have certainly gotten better. Spine MRIs, and especially the thoracic cord, the lower spinal cord, for whatever reason, we still sometimes see a decent amount of kind of graininess or fuzziness in those images. And sometimes that could just be because, it's impossible to really fully stop moving because you're going to breathe. Your heart's going to beat, you're going to breathe. When you're lying there in the scanner, they're like, stay still. So it's impossible to like really do it completely. And I think there's probably some facilities and some equipment that are, just kind of better than others, kind of thing. But you still will sometimes see kind of grainy cord images. Credible source of information about medications, like cost, where they're administered, recommended follow-up. I think we're a credible source. So talk to your neurologist. You can also go to our website, mscenter.org. National MS Society has a good website. And otherwise, stay off the internet. I think there's probably some good information out there. Actually, there's a little question now about ChaptGPT, so I'll save that, my musings on that to the end. Yeah. And then, is there a national MS organization or grant that provides equipment, assistance, transportation, mental health needs, family counseling? There is our organization. So Recommend MS Center, and we certainly do at least some of that. There's the National MS Society. There's the MSAA. So there's like a few, organizations there. And I think Kelsey mentioned, so afterwards she's going to give a kind of a rundown of some of the things, services that we offer. But check us out at the website and contact somebody there, and they can hopefully get you what you need. Does a PEMF mat help? I think we've had earlier questions about this, and I think I had to look it up before. It's this kind of an infrared mat for MS or something. I don't know if it helps. The website looked like it was selling it for a fortune, and so if somebody's going to gift it to you, sure. Yeah, but otherwise, I probably would just, oftentimes I learn from what you guys tell me. Like, hey, doc, have you heard of this thing? No, well, I tried it and it's great. I'm like, oh, okay, great. And if enough people tell me that, then I might start to be like, I have several patients who've tried this and they think it's great or they think it's terrible. So I do definitely learn from what you guys tell me. And so in some cases I might be like, oh, well, I don't know if it's good or not, but it's readily available. It's not going to cost a fortune, and it's probably not going to hurt you. So yeah, give it a try and let me know, kind of thing. In this case, it did seem kind of expensive, so I probably wouldn't do it myself. But but we don't know. A lot of these devices and things we don't know if they're helpful. There are some things that we have some sense, things that our rehab colleagues will use. So, canes, walkers, ankle foot arthrosis, braces, things like that. And then they're starting to use more of these FES, functional electrical stimulation devices, like the Bioness makes the walk aid, and then psionic neural sleeve. So there's these things that you put on, and then they send shocks to your muscles, and they cause them to contract. And if you can't move that leg before, now you can move it, and it's great. At least as long as you have it on. So yeah, there are some devices that we think are doing something helpful. But I'd say there's probably a lot out there, like with the supplements, that's just unproven. Okay, on to the last stretch, it looks like. Kelsey, I'll just repeat it. Okay, she asks, do those devices not strengthen the muscles? Do they just stimulate them? I don't know. I think, yeah, they're supposed to be billed as these kind of promoting neuroplasticity, rewiring kind of things. But I don't know. When I've seen people not use them, they're like, yeah, now I can't move my leg anymore. So I don't know how much actual repair is happening versus like you're using it because there's a shock that's going to it kind of thing. Okay, so what type of diet or foods best mitigate MS symptoms such as fatigue, joint pain, and coordination? Briefly, there's a lot of different diet. None of it has been proven to like the highest standard, in terms of large scale, really randomized control trials. There are some people out there in the MS world who are trying to do stuff like that now, but it's challenging. It's challenging for a few reasons, but mostly it's hard to kind of randomly assign somebody to blindly randomly assign people to this or this diet and then expect people will continue with it kind of thing. And so we get our evidence from other from questionnaires and from other sources that are kind of less scientifically rigorous. Excuse me. But given all that, I mean, there are some kind of themes that keep kind of coming back, and we have some idea that like I said, a balanced, healthy diet. Well, what does that mean? It's not balanced with like donuts and candy and ice cream. Like, no, like most of the diets they're looking at like things like, paleo or the Walls Protocol or keto or things like that involve kind of restricting, carbohydrates, restricting, sugars and things like that. And so I don't necessarily recommend any of those, and I don't know that there is a one size fits all for diet. I think find a kind of a pattern of eating that you're comfortable with that is healthy. And if you need help defining that, we can help you define that, and try to stick with it, So the diets that have probably the most evidence behind, at least, in some of the kind of patient-reported things, I feel better, I have more energy kind of thing. Things like the Mediterranean diet, South Beach Mediterranean. So things that are not like so drastic, right? They're popular diets for, other people, right? And those seem to have kind of more evidence behind them in MS, but still not like we can necessarily, recommend it for all people. I have been told that my MRI showed the volume of my brain is smaller than someone normal for my age. I'm 63 and was diagnosed with MS in 2004. Other than normal aging, what could be the cause of this decreased volume? The MS could be the cause of the decreased volume. We know MS decreases kind of prematurely the volume of people's brain, and probably their spines too, if they have spinal cord disease. And that's something that we would like to prevent. So when we talk about potential neuroprotective therapies, a lot of what we're trying to do is prevent volume loss, prevent the destruction of those neurons. And one of the ways we measure volume changes is doing these volumetric studies on brain MRIs, which I think they have some value to us, and certainly they'd be even more important if we could actually kind of change that, do more to protect from loss. Our disease-modifying therapies currently, they maybe like Ocrevus slows down like a little bit the rate of brain volume loss kind of thing, like 15-20% in that range. But that's not that great. And so it's a number that we look at. We can now measure more with certain MRI techniques, which insurance companies are trying not to pay for, and we think it has some in kind of progressive decline, cognitive decline and physical decline. Although the physical part may be more if we were to measure again kind of how much volume is in the spinal cord in addition or by itself. And so yeah, so we can measure it. We'll probably keep trying to measure it in more accurate ways, and maybe involve more of the nervous system. And then hopefully we'll have something that can actually, if we do see, and that's the other thing, is that this question doesn't really say that it's changing in a longitudinal way. It just says compared to peers, which tells me basically nothing. I mean, it's that, yeah. So people have different size brains, just like they have different size feet, and it doesn't necessarily tell me anything really about the power of the brain, the power of the mind. It's really not how much you have. But if we know that you have a certain amount, then we are going to try to prevent you from losing it to the extent that we can. And so hopefully, we'll be able to kind of measure those changes a little bit more accurately, because right now it's kind of not that accurate. Number 23. Okay, my wife has MS. She has numerous lesions in the brain and spinal cord. Diagnosed in 2004. She's 63. She exercises daily, though feels she is not able to gain much strength or improve her endurance. Is she fighting a losing battle? No. Well, I mean, we're kind of all fighting a losing battle against time in some sense, but no. I mean, I think, and it doesn't tell me here like how much kind of function this person has. I mean, maybe she's like lifting 300 pounds and she can't get any. She's reached her max. Kind of thing. So, I mean, there's so much that could go into that. For one, I mean, yeah, I'm not that old, but I also feel similarly, kind of thing. So there is a certain, as we age, we don't have the same endurance, and we can't put on muscle as easily. And that's just part of aging sometimes. We definitely recommend that people really kind of, regardless of their what they're able to do, try to move your bodies in some way, on a regular basis. And it's a cliche, but with muscles and like brain, you use it or lose it. And so that is one of the only things really, especially for folks who are weak in the legs, they want to know what they can do. There's not really a pill I can give you that's going to strengthen that. It's more just about you putting in the effort, doing those activities that are recommended by, say, a physical therapist, and trying to preserve or even potentially build those muscles. But it won't necessarily be easy, and it might be harder with each advancing year. But we think it's very important. Okay, on to the ChaptGPT question. So how has ChaptGPT affected diagnosis or treatments, if any?
Dr. Griffith, can I add on also, we had a question from the chat, specifically wondering if AI is helping compare like brain volume and lesion load between MRI scans.
Good question. Let me answer that last one first. I don't know. There's a special software that we use at the university called Icometrics, or that's the company that produce the software. The computer may, I don't know, it may use some kind of AI. Well, the problem though is not that. The problem is the acquisition of the data that we're not entirely convinced is, represents the truth, because we know that brain volumes can vary from like hour to hour, for instance. And so it's not that we think the AI is like hallucinating or anything like that. It's just that we don't know how accurate the measurement is right now, which is not done by AI. But how is ChaptGPT or AI generally kind of affected diagnosis and treatment? It's a great question, and it's here. It's here. I don't know if you guys do a lot of kind of internet searching lately. You're getting answers to things that are like, I mean, in some cases. So I myself have not used ChaptGPT or really the internet, like Google search, like towards diagnosis or treatment recently. I mean, I usually will go to just a a doctor website that I know that I'm familiar with that it doesn't use that. But there are doctors, colleagues that I know that do and have recommended that I look in. So I actually have been thinking about doing that. But because I mean, and from a doctor colleague that I recently spoke with, it seems like it is quite accurate. And I know that they've done studies and looked at things like how good is AI at like picking out lesions on an MRI scan, for instance, compared to like a human. It's better, not so surprisingly. But so I mean, I can certainly imagine using it as a tool, and in fact, it's already being used as such, like in radiology and other dermatology things where it requires pattern recognition. But I think in the coming years, we're probably going to see a lot more, and I think they are integrating it into our kind of medical record system very soon, if not now. The only way that I've used it so far really is, we have to, file appeals on your behalf sometimes to get drugs, and that's a lot of paperwork and it gets tedious and stuff. But if you say, hey, ChaptGPT, can you write this, appeal application to the person's insurance company, explaining why I think they should go on, Ocrevus or whatever drug, and and making sure to include this and this, it'll do it. It'll do it like that. And it'll do a pretty good job too. So it's definitely saved a lot of time. I was just, little tangent, we have a minute, right? I was just talking to a lawyer friend the other day, and basically it was just like, yeah, all the law jobs are going to be gone. Yeah, certainly the idea of like billing on time kind of thing, because like you can spit out this 25-page brief or whatever in seconds, and then you have a semi-competent lawyer kind of look through it and be like, yeah, actually that looks pretty good, and I would have billed like 100 hours for that or something like that. So it's definitely saving time, and my understanding is, again, not having used kind of specifically in the medical applications, that it's getting pretty accurate. And so yeah, I mean, they're coming for our job. If it takes my job, I think I'm okay with that. I think I'll find something else to do. But I think at least in the near future, it's probably going to end up being used kind of more as a like a helpful tool. Questions from the audience. So that's it for questions from here. So, and I think
we did have one more online, and then I'll come around to you guys. And you kind of went over this a little bit earlier, but can you list the current top studies or trials relating to remyelination?
Not really, not off the top of my head.
I think at ECTRIMS, was there an announcement about clemistine and metformin?
So clemistine and metformin, I can talk about those briefly. I don't know what the announcement. Do you know what the announcement was? No. Okay. Well, you can pull it up while I know. So clemistine and metformin, these are two existing drugs that are trying to be repurposed for neuroprotection and remyelination kind of thing. So early studies suggest maybe these could be useful. Let's actually study them in large groups of people with MS. And this particular study with these two agents is being done currently in the UK, I believe still currently, unless I hear differently in the next few seconds. And it's looking at their potential, benefits in terms of neuroprotection or repair. Potential, right? We don't know yet for sure whether they do that, but we do know something about their safety because these drugs and tolerability, these drugs have been around for a while. Metformin is a medicine that's commonly used in like diabetes and metabolic conditions. And it's been used for dozens of years by millions of people, and it's like, people know the safety profile and so forth. And then clemistine is kind of an old school antihistamine agent, so kind of like a Benadryl kind of thing. And I believe that PIPE 307 is also working by a kind of a similar mechanism as the clemistine on what's called a muscarinic receptor. So it's so that may be why if if it does work, that it does work. But I think we don't know yet for sure. Is that accurate?
Yeah, it was not a conclusive trial by any means,
Okay.
but just another trial showing that it does have remyelination affects the combination of them.
Yeah, it's a weird design. It's being done, the two of them together. So I'm not entirely sure how they're going to be able to say whether, if it does work, whether it's one or the other, or maybe they don't care. Oh, it's good enough. One of them works. But it does speak to this idea that we need, because, we need to have a better pipeline, I think, too, for coming up with remyelinating, repair agents and neuroprotective medicines. Because the way it works right now, from the time somebody first comes up with this brilliant idea that this thing could work to when it could potentially get in the clinic is like, no, it's a long time. It's years, right? And you only ever end up seeing like probably a small fraction of all the good ideas that are out there, the ones that somebody has put in the effort and money to make it, in a trial. And often that's not even like a large phase 3 kind of, $100 million study. That's like a smaller, a couple dozen patients here and there, kind of trial. Because, the truth is, especially if we're talking about kind of these repurposing older existing medications kind of thing, it's not sexy. It's not something that a lot of pharmaceutical companies are going to get behind and be like, yeah, that's where I want to spend my R&D dollars. So it has to come from, investigator-initiated projects and things that are supported by like, grants from nonprofits and the government, So that is, kind of the, some of the stumbling blocks. And there's not an infinite number of people with MS either, right? And so, you're the most valuable resource to us. And so, we don't want to like put you in trials for things that we really don't think are going to work. Or, so there's a number of things that kind of go into kind of how these trials get put together. But we need to be a little bit more creative in terms of kind of how we judge things are helpful or not, and how we, do this pipeline from getting the idea to actually helping people. Yes.
My question is reference, I think the company is Octave or Octiva that does blood work tests.
Do you work for them?
Biomarkers in the blood.
Yes.
As predictive for current or possible future MS activity. To use those blood tests as part of your tools in your tool bag?
So the question came from a gentleman asking about biomarkers that are being produced and marketed by this company Octave to monitor MS, and I was asking kind of facetiously if you worked for them. Okay, so maybe I don't use them personally. I know they offer this whole panel of blood tests that they say is going to really kind of very closely monitor the goings on in your body, in your nervous system. At least a couple of them, I had an interest in kind of this biomarker area, and I've looked at a couple neuronally derived or neuro and glia or other kind of supporting tissue derived proteins, so found in the blood that would hopefully be able to kind of offer some idea about what's going on. So I looked at a couple of those markers, and they did seem to kind of, generally speaking, kind of go up or down, for instance, like, after an attack or as somebody is getting worse. But it wasn't like super, like, every person who had an attack had this amount of going up, that the relationship was like extremely clear and like this. So the way I understand when I saw their data a few months back was that they can find the pattern and correlate it with kind of how somebody is doing right at that moment, but they have not tested that as a predictive tool for where they're going to be in a year, 3 years, 5 years. I think they definitely want to do that, and that would be by far what would be the most useful to us. But that, as I understand it, has not yet happened. And so, okay, 0 minutes. Well, I'll finish answering that question and then maybe just one more? Yeah. Okay, so yeah, I think biomarkers are important, and ideally they would be something that is like easily obtainable, so not necessarily by doing a brain biopsy every time you want to get it. And they should tell us something meaningful about a person's individual kind of trajectory, you know, a hemoglobin A1C test for a diabetic. You know, it's up when they're doing badly and it's down when they're doing well. You know, that's what I want to see. That's not what MRIs are currently telling us for the most part. Yes. And so there was a question earlier about B-cell therapy monitoring with anti-CD20 cells. So basically, all the blood tests we currently use in clinical practice for the most part are not to necessarily see how your MS is doing. It's to make sure we're not causing you side effects, right, with our drugs. But ideally, we will have other blood tests, and they're also they are, to be fair, being used in some places. I know, in some centers, but you know, until we have that kind of more robustly, then yeah, it's mostly we're just getting information about how we're hopefully not harming you. Yes, another question. No, anywhere else from the group? One more? No? Okay, good. All right, we got them all.
Thank you guys. Thank you all for your questions. Thank you for being here. Everyone has evaluations in front of them, or the link is being posted online. So please fill those out. I do use all of that information. And then I just wanted to share also some of the topics that came up tonight. AI in particular, again, we're going to be talking about that at the Ed Summit, as well as research updates. So any of those new remyelination information we'll be sharing. And then just a reminder that we have a lot of older resources on our YouTube channel, as well as mscenter.org. Both of those places have a spot to search for specific topics. And these events, this conversation series, when we do these, you know, we ask 30 questions. I put in a chapter list that has every topic that was discussed at that event. And so when you search in YouTube in the MS Center website or channel, you're going to get every question we've answered on BTKs or whatever the topic is. So I highly recommend, if you've got a specific interest, to do that, because you'll hear kind of the same responses, but from different doctors. So they'll give different information, different perspectives. And some of the topics that I know we have a ton of stuff on that came up today, the BTKs, cognition, vision, the new diagnostic criteria, kind of how to weigh risk and benefits of medications, and disco MS. We have lots on all of those. So please check out the website. And again, thank you for your time. Thank you, Dr. Gross.
My pleasure.